So, just presume any medication I talk about that we do some research in or have some other disclosure about. And Gil Melman, I believe, was the original creator of this slide set. So if you have any critiques, you can send them to him, not me. The important thing is, if you're going to remember anything from this presentation, is that we don't just treat Crohn's disease now by asking someone, how you doing? And if they say, I'm doing fine, you say, okay, whatever we're doing, we'll stay the line. You have to prove that what you are treating them with, even if you're not treating them with anything, is working. Prove it objectively, meaning with a scope, in Crohn's or UC, with radiographs in Crohn's of the small bowel if it can't be reached by a scope, by other objective markers, fecal calprotectin, CRP. And if they're not normal, you escalate therapy until they are. That's called treat to target. That's the end of my lecture. Who's next? No, because, yeah, right. I mean, we're going to show you data supporting this, but that's the bottom line. And like I said, how sick is the patient? And then there was this treatment pyramid that unfortunately people developed. Oh, is there a pointer? Well, anyway, you can read it. There is a pointer. Look at that. And then you tailor treatment to symptoms. And even when I trained, it was told, oh, you know, how do you decide if you're going to scope someone? Well, how are they feeling? Are they feeling good? You having a lot of bowel movements? No. You having blood in your stool? No. You having pain? No. Like, what are your kids doing this summer? So, but what actually happens is Crohn's and ulcerative colitis, particularly Crohn's, is a chronic progressive disease, and it progresses really slowly. So if you don't act when the patient still has inflammatory disease, you're going to end up being a failure because that patient is going to end up most likely stricturing and possibly having penetrating disease. And you've missed your opportunity to treat them. I'm going to go to the next slide. So in 2014, there was the AGA clinical pathway for Crohn's, and then the one for ulcerative colitis came out. And this was solo authored by Bill Sanborn. I think many people would disagree with low-risk patients of just giving them steroids or budesonide and then kind of doing nothing, because I think that's the opposite of what we're talking about now. I think that really, in reality, unless someone has very, very mild disease, you really want to get people on effective therapy for Crohn's disease and prove it's working. So for patients other than just very mild disease, you're looking at, and this was in 2014, anti-TNFs with or without thiopurines or methotrexates, and moving forward to 2019, we have FDA-approved therapies not just for anti-TNFs, but alpha-4 beta-7, IL-12, 23. It looks like the combination therapy with azathioprine, 6-MP, or methotrexate, the data for the anti-TNFs is there. It's less clear whether that really makes a difference in patients who are on ustekinumab or vedolizumab, unless you want a separate therapeutic benefit. And then even combining biologics or biologic with a novel small molecule, that is what we're doing now, or thinking of doing now. So the old ways, you had single drug trials, but now there's whole algorithms of care, combination drugs we're going to talk a little bit about, and something called comparative effectiveness trials, where you say, okay, these are trials you've done at different times, different generations. Sometimes the FDA had different guidelines, so how do we actually compare and how these things work? And this is, again, so you heard my initial thing. It said, if you remember anything, it's the treat to target, make sure people are objectively better. And this is why. So let's say you were taking the dreaded board examinations or the even more dreaded recertification of the board that hopefully we'll be getting rid of. The typical Crohn's question is you have some 24-year-old who goes to the emergency room with appendicitis. Whoa. By the way, to the future speakers, this is mobile, so if you lean against it, you're going to pitch over, okay? Yeah, that would have been really exciting. And we definitely would have had the next speaker then, too. Well, can I turn it this way? Okay. So basically what it is, so the kid's in the emergency room and appendix, oh, it's not the appendix. They go into surgery and the appendix is normal, it's sitting there, right? But you have this long strictured area of ileum. And maybe they take it out, maybe they don't, whatever the case is. Then the patient appears in your office and they say, well, how long do you think I've had this? And you say, oh, you've had this condition for years, 6 years probably. But the inflammation was happening so slowly that unlike an appendicitis or a gallbladder attack, it wasn't acute. Your body's actually been thickening, covering up the areas of inflammation by bringing in scar tissue. And that's what shows here. You can see that the top line here, this is the disease is progressing in this kid They had symptoms here when they went maybe to the emergency room or maybe initially saw a local doctor with some pain. They said, oh, you have irritable bowel. But in reality, it's progressing. And by the time that there's something to do, they're already a surgical case. So, and probably, how many of you are pediatric, in pediatric practices? Okay, Marley, raise your hand, right? Well, Marley's like everything. Isn't she wonderful? So there are a few people who are pediatric practice, but most of you are in adult practices. And a lot of the times, by the time you see your Crohn's patients, the cat's already out of the bag. They already have their inflammation, their stricture, it might be. So your chance to make a difference may have to be after you remove that stricture. You send them to surgery, ileocystectomy, and then as Miguel Reguero knows, because he invented the treatment for Crohn's disease, you put them on effective therapy after that, and you can prevent the disease from coming back again. Oh, wait a minute, you're not at Pittsburgh anymore, so you're not part of the team that invented the treatment of Crohn's disease, according to their marketing people. We just like to throw little jabs. I shouldn't have done that because I am the first speaker, so he'll be able to have a comeback later on. Maybe I'll be at the airport by then. So, comparative effective. So what the heck does that mean? It means you have two therapies and you see which one works better, et cetera, too. So the most common one we've talked about for years is called the SONIC trial. Patients with Crohn's who never were on anything real for their Crohn's disease were randomized to start on azathioprine 2.5 mg per kg, infliximab, or both. And what showed that combination therapy was better than infliximab alone, which is better than azathioprine alone. Although we did find out that patients who had good infliximab levels, that was probably the real key, and the azathioprine was helping that. There's only been one currently widely presented head-to-head between the different biologics, but there are a few underway. And it is difficult to look across trials. There's different endpoints, there's different patients, maybe they're done in different countries. So sometimes what people do is they say, well, what's the benefit over placebo? But I actually don't buy that as a legitimate comparison. For Crohn's disease, we have FDA approval for the anti-TNF therapies, vedolizumab, ustekinumab as the biologics, and that's because they work. There have been systematic reviews and network meta-analyses. How many of you have ever done a meta-analysis? Right, where's Ash? Okay, so how many of you will ever do one again? So one of the issues with the meta-analysis is you actually have to make sure that the papers that you're combining, the trials you're combining, actually you can combine. And while you do look for heterogeneity between the different studies, it's sometimes questionable what you can really do. So there was I think this was one of the questions that Marla asked. The only widely published head-to-head trial so far, of my knowledge, is the Varsity trial, and this is a precursor to what we're seeing in other trials. They randomized patients. This is an ulcerative colitis trial, although this is a Crohn's presentation, to vedolizumab versus adalimumab, and it was double-blind, double-dummy. The patients were randomized to either therapy, so everybody got treatment. So that's nice because it's easier to recruit in a trial where people don't just get placebo. And there was no dose escalation, and it was a one-year study. And the endoscopies were essentially red, which is important. And these were, again, this is an ulcerative colitis trial. The vedolizumab data is in red. The adalimumab data is in blue. Overall, you can see a benefit at the 52-week time point, but you can see, particularly in the TNF naive patients, it seemed to work better. There were patients who received TNF that were allowed in the trial. Some people think that's not really fair because since adalimumab is an anti-TNF, you might be selecting against it. But nevertheless, the purpose of this is that we're now getting head-to-head trials. Comparative effectiveness trials for first-line agents for induction of remission in Crohn's disease. So this is Crohn's data, and basically the odds ratio, what you want the odds ratio to be is high, and you can see that particularly for the anti-TNF agents, there was in their trials this higher odds ratio of patients getting induced with clinical remission for Crohn's disease. This is not ulcerative colitis data, this is Crohn's data. You can see, though, that the therapies did work, and as you know, being prescribers, you choose different therapies for people for different reasons. I think the important thing isn't as much what therapy you choose, but that you choose a therapy, you get the patient on, and then you evaluate with an objective means to prove it's working. And if they still have inflammation, even though they feel fine, you adjust the dose, you add in combo therapy if appropriate, and if it's still not working, you may consider changing therapies. If you check drug levels and antibodies, let's presume they still have drug, they don't have antibodies, you've gone up on the dose, they may just have a different mechanism. And you know, until 2014, all we really had were anti-TNF therapies for the treatment of Crohn's disease. Some of us did use natalizumab, but it scared everybody away. So in reality, you didn't really know those options. But the exciting thing is, how many of you guys walked out and you saw all the different booths that were out there too? And thank you to the supporters of these educational events. There are many different therapies, not just in the same families that we have up here, but even in additional families that are being developed. So again, the whole point of this lecture, and this would be the same if I was giving the ulcerative colitis lecture. Who's giving the ulcerative colitis lecture? Oh, that's like you, right? Okay. The whole point of this is that you treat to target, and I guess this is both Crohn's and UC. This lecture, right? This is the okay. Yeah. This is the IBD one. Okay. I'm going to go back to the beginning and start all over. Good to know. Right. So the point is that your target is the mucosa looks normal in UC. In Crohn's, since it's transmural, probably radiographically too, that your inflammation is under control. If they do have inflammatory markers that are elevated, CRP or fecal cal, they're normal, or lactoferrin, and that's your target. If you're not reaching it, do something about it. It is important that patients feel well. Patient-reported outcomes are important. Why? Well, let's say Marla invented the best therapy for Crohn's and ulcerative colitis. Okay, she actually has in her luxury Manhattan apartment, she has her own laboratory, and she invents this therapy, it erases all the disease. However, it gives patients horrible diarrhea. They're not going to take it. So the patient-reported outcomes are important, but they're part of the outcomes. So for many years, this is over 10 years old, this top-down or bottom-up study. Because we were telling people you have to be more, I don't want to use the word aggressive because it's kind of a negative term, but you really have to be more active in managing your patients. And they said, prove it. Prove it makes a difference. And the reason why they wanted you to prove it is because of mostly economics, but also safety. So these patients with Crohn's disease who never were really on anything effective were randomized blindly to get, if they had active Crohn's, moderate severe Crohn's, steroids, then another course of steroids, then azathioprine or methotrexate, and finally infliximab, if they failed all these, which is really how most people not only had been practicing, but still are practicing, and they shouldn't be, or 3 doses of infliximab, week 0 to 6, plus azathioprine, 2 mg per kg or 2.5 mg per kg. They didn't give maintenance infliximab because this was done in Europe, and they were cheap. They didn't want to spend any money on this, so the only time they got infliximab again is if they got episodic infliximab, and then only at the end of this, steroids. In this group, the first year, not one of their patients ended up on steroids. Not one of their patients ended up on steroids. And then here are the outcomes. Remission at 1 year, over 60% if you did it with the infliximab right off the bat, versus 42% with the steroids, methotrexate, azathioprine, infliximab. And when you scope these people at 2 years, this is the most impressive. Look at this. 73% of them had no inflammation on their scope. 73. Show me another study that shows that data. That's amazing. This shows that early intervention can make a difference. And then if they looked at if you had a simple endoscopic score, so how many of you calculate the SES on your Crohn's patients? 1, 2, yeah, because you guys are researchers, right? But Americans don't do that, and we're not going to, so I'm not going to show you the scale. It's impossible. The only people who do it in our practice is Sushi Sakuraba, because he's Japanese. He's very precise about things, which is helpful sometimes. So the remission rates in patients who had a simple endoscopic score were 70%, but if they had any inflammation, look at the difference, 27%. Remission off steroids and even off anti-TNF. Big difference. And here's the time to relapse. So if they got the TNF right off the bat, here's the green, versus those who didn't. The people who didn't, and that's how most have been practicing, would relapse rather quickly. So that was that trial. And then more recently, it was much more recent, just a few years ago, there was this REACT study. And this is completely different. This is an open label, okay? Patients were just randomized one of two practice arms, accelerated treatment or usual care. These are bio-naive Crohn's, but it's open label. So that really, I think, unfortunately, really compromises what you can know. And it's very, very complicated. I'm like looking at this last slide, I'm like, you kidding me? So what happens is that the patients get steroids, and then if they're in remission, you taper it, and then you reassess. And if they have active inflammation, you add azathioprine or methotrexate. If they weren't in remission, you added azathioprine and adalimumab. Unless they couldn't take azathioprine, then you got the methotrexate and adalimumab. And then you would just go up on the therapy, switch therapies, go to a different anti-TNF, so much more active treatment. And look, there was no difference. There was no difference between the patients who you started right off the bat on the adalimumab and the immunosuppressant versus those who didn't. And people said, aha, see, the early interventions don't make a difference. Again, open label. But there were some differences. And what I'll show you is in the top left, so the red line is conventional management, and the blue line is the who had early adalimumab and immunosuppressants, et cetera, too. And the surgical rates were much lower in the patients who had the early intervention. The serious complication rates were much lower. The hospitalization rates were not statistically different. They were slightly lower. But when you do the combined endpoint, there was a big difference, a quarter versus a third of the patients, too. So we think there actually is data in there. It's just hard in an open label trial to show that. Subsequently, oh, look how much time I have left. How many slides are in this slide? Oh, I don't know. So anyway, so the COM trial, this is actually another study looking at the idea of tight control versus what we generally do, is you had one group that the decision on what to do is based on the Crohn's disease activity index, basically how the patient was feeling, and whether they needed steroids. The other group, it was the same, except you also got a fecal calprotectin and a CRP. So the point is that in one group, your decisions to treat were based only on their symptoms and if they needed prednisone. The other group, they were also based on whether they had high CRP or fecal calpro. So even if they were feeling fine, if this group's fecal calpro or CRP was elevated, they escalated therapy. And the therapy escalations, you can see here, which you can't read because you're too far away from the screen, but I can read it because it's right in front of me here, adalimumab, then adalimumab every week, and then add azathioprine. And here's the data. The patients in whom you made clinical decisions based not just on their symptoms, but also CRP or fecal calprotectin, at 1 year, almost half of them had mucosal healing versus a third of them where you just did, hey, how you feeling and whether you needed prednisone. So this is more suggestions that you should use objective measures. This is the same slide I just showed you, and this shows deep remission and biologic remission. Basically, the blue is bigger than the aqua blue. They should have done a different color, maybe like a yellow or pink. But what cost? Well, this was, again, a European study, so it's in euro, okay? So euro is worth, what, $1.15 or $1.20 or so, right? So sure, the people who had tight control, you did end up spending a little more money on them. Their quality-adjusted life years were better. So the cost-effective ratio per quality-adjusted life year was about 20,000 euro. So again, just beating the dead horse, the recommendations in Crohn's disease from the STRIDE recommendations, which are from the International Organization for IBD, which basically go to really nice meetings once a year at some exotic places, and then decide that they have to come out with some endpoints, otherwise people won't believe them, is that you don't just do the clinical, but you also do endoscopic. So for Crohn's disease, you actually have to prove endoscopically or on cross-sectional imaging after 6 to 9 months that the patients are actually better, and you can check calpro and even look under the microscope. And for ulcerative colitis, you don't need the cross-sectional imaging because it's a mucosal disease, but in ulcerative colitis, the clinical remission of resolution of bleeding and bowel habits, but also your scope should be healed or nearly healed, and adjunctively you can look at the CRP, fecal calpro, or histopathology. So this slide, this came to me, this slide's from Gil. I don't know who this kid is. I hope it's not his kid. It doesn't look like him, so it's probably not. But I thought it was kind of funny, so I kept it in here. So sometimes you actually can't get there. And particularly if you're an adult gastroenterologists practice, or in their practice, a lot of times, especially with Crohn's, your patient is just going to need surgery. So you can also say, you know, if we got a patient, particularly with Crohn's, who has a stricture, and they have good levels of a biologic, and they still have obstructive symptoms and problems too. They've never had surgery before. I mean, these are or they have, it's just a short segment. It may be better just to take that out, primary anastomosis, before they get really, really sick and malnourished, and then treat them from there. The risk stratification, the patients who are younger, who have more extensive disease, perineal disease, deep ulcers, stricturing, or in Crohn's disease, that says the same thing. So look and see what's going on. What does it need? You have to reassess patients, even if they're feeling fine. Prove that your therapies are working. Just what I'm saying, you risk stratify by their prognosis. You identify your goal. What is my goal? Healing mucosa, getting rid of their disease. What am I going to do if it doesn't work? I actually put that in my notes. If this doesn't work, we're going to do that. Why? Because let's say I get hit by a bus, right? My nurse will know what to do. What was I thinking? Okay? I always prepare people for what might happen. You never know what's going to happen to you. And now, and this is actually the last slide, they've developed, Corey Siegel, who's somewhere north of here, they actually developed this tool where the patients can understand. They plug in their different risk factors and get an idea of what's their risk of getting bad disease. And that helps convince them that they may need to do something about that. Thank you very much for your attention.